ahead.
Okay, recording has begun. And just remember too, for those who weren't able to join us this evening, we'll be posting this to our YouTube channel on the website, so people will be able to take a look at it afterward.
Excellent.
So welcome to the Human Services Committee meeting. Thank you for coming. Thank you to our guests. We have Nina is co-chair with me, and the presentations tonight really apply to Nina's line of work. So she should really be directing traffic here tonight, but she's walking now, I think.
Yeah, unfortunately, something I got stuck out. I'm usually home earlier, so I'm out here, but I'm listening and I'm tuned in and I'm safe and I'm fine. So, yeah, let's hear
go.
from others.
So we have an agenda, and the first item on the agenda is maternal and perinatal health services presentation by Berenice Kernizan. Is that how you pronounce your name? Close?
It's close. Berenice Kernizan.
Kernizan. Okay. And you are the coordinator at By My Side Doula Services at Healthy Start Brooklyn. Is that part of the New York City Department of Health and Mental Hygiene?
Yes.
Okay. And part of the Health Equity and Community Wellness division, I guess. So you have the floor. Tell us maybe a little more about, what you do, and then go for it. Thank you.
Sure. I actually have some slides, if that's okay, I'd like to share.
Sure.
That'd be great.
Sure. Sorry, give me 1 second.
Okay.
Okay, you should now, yeah.
Let's see. 1 second. And it's going to be the slide that is, hold on a sec. The little bar at the top is blocking me from seeing the rest of my tabs, and it's the tab. Let's see if I can. I'm gonna pause the share. I'm gonna stop and then rearrange the tabs so I can have access to the one I actually need. Put it in the very front. Okay, let's try that again. Share. Aha. So everyone should be able to see a teal screen. Did anyone see it? Okay. Awesome. So again, I'm Berenice Kernizan. I am the By My Side Doula Services Coordinator. So let's just get started. So a little bit about what doulas are first, right? In the US, I'm just gonna read from my notes. The US is the only industrialized country where rates of maternal mortality and morbidity are rising. We are also spending the most money on healthcare per capita. What are some solutions to this? The use of doulas has been identified as an effective intervention that can help to decrease the racial disparities and improve birth and maternal health outcomes. But what exactly is a doula?
Yes.
So a doula is a non-clinical birth professional. The doula's role is to support a pregnant mom in labor emotionally, physically, and also by providing information throughout her labor and also prior to her giving birth. So typically a doula meets a mom before she gives birth and creates a birth plan with her. And then the doula is on call for mom starting at 37 weeks. And when mom goes into labor or the pregnant person goes into labor, the doula is there to support her. And also we provide a couple of postpartum visits as well. So what do doulas do? So doulas do a lot of things. So if you focus on the left-hand side of the screen, you'll see that, like I mentioned, the doulas also help with birth plans, right? So really getting the individual that's going to be laboring to think about what their choices are in labor, right? To get them to think about how they would like to spend the various stages of labor, and kind of speaking to them about what their hopes and wishes, and maybe if they have any fears and concerns, kind of getting to the bottom of that to really be able to help support that person and provide advocacy in the birth room. So during labor, the doula is there to provide continuous physical and emotional support. That can look like a hip squeeze, which is something that the doulas do when the mom is in labor to help alleviate the pressure from the contractions. Back rubs, words of encouragement, helping the partner take breaks, and etc. So we also provide tips for making labor more comfortable, including position changes, getting in and out of the shower, etc. Like I mentioned, we're advocating for the individual. So doulas, we're not making decisions for that individual. We're just saying, hey, here's option A and option B based off of what the provider has said and helping them to make an informed decision. So we would like to call that informed consent and informed decision making, right? So after birth, a doula will flag any warning signs with you or your baby. So again, we're non-medical, so we're not making any assessments. We're just, speaking to mom, seeing how she's doing. And if there's anything that's a little bit concerning, we'll say, hey, maybe you should reach out to your doctor, or maybe you should go in and get checked in before that 6-week traditional postpartum visit, right? So we're also checking on mom at home to see how she's adjusting and the parents are adjusting to the new baby. We're normalizing the transition to parenthood or a new addition to the already existing family. And we're encouraging clients again to seek support as needed. So it can be support as far as like breastfeeding support, mental health counselors, etc. So the By My Side Birth Support Program serves Central Brooklyn and Eastern Brooklyn since 2010. We're funded by the Healthy Start Brooklyn grant, which is a federal grant, housed within the NYC Department of Mental Hygiene, Health and Mental Hygiene. So when you think about the Department of the DOH, you could think about Healthy Start, and then By My Side Birth Support is under that umbrella. So a lot of terms to say all of that. The By My Side Birth Support Program, you might recognize the name, the By My Side structure of the program itself, as because the citywide doula initiative is based on the work of the By My Side Birth Support Program. And we've been doing this work for about a decade, right? So again, we've been providing free professional support in labor and delivery, plus 7 home visits. And those visits are prenatal visits before the person gives birth, and then we have 4 postpartum visits that we do after. And of course, not forgetting the most important thing, which is the labor support during labor, which can be X amount of hours, right? No one really knows how long labor is, so the doula is there to support as well. And I think one thing I forgot to mention was that in between those visits, the doula is also in contact with the pregnant person, right? So that means that they have the doula's phone number, so the client can reach out to the doula whenever she has questions. She doesn't have to wait to the next visit. So they are also building a relationship to help strengthen that that bond and just the partnership in which they'll be in when labor gets started and after. Let's see. And so we've served over 1,000 births since 2010. And again, we're doing screenings and referrals and just really connecting clients to services. So By My Side, we're community-based doulas. And that's when we speak about referrals, we're speaking about mental health resources. Let's see, there's a mom perhaps facing, issues with ACS. We're there to support them also and guide them in the right direction of where they can help find a parent navigator who can help them through those systems, right? So the impact of doula support. So if you can see here, what's going on is that this big slide just basically says about 4 things, right? Doulas, we improve birth outcomes for all. We improve health equity, right? Making sure that, there's a big difference between equality and equity. So when we speak about equality, it's different from equity, right? So equity means that we're providing people to access, right? Clients or anyone to access. For example, if someone lives in a food desert, we figure out how to get them to meet them where they're at and provide those accesses, and not just saying, oh, well, there's a supermarket about a mile away, right? Because that would make it, if we say that in a sense, for example, we're assuming that that individual has a way to get to that supermarket, right? And we're not really thinking about how to meet them where they are to provide them with that equitable resource. And then also we're enhancing the experience of care, and doulas are also cost effective. For example, each C-section avoided provides $4,459 in medical care savings. There are higher breastfeeding rates to both short and long-term costs for both mother and baby. And doula support during pregnancy is associated with the reductions in preterm birth and low birth weight, which are leading causes of infant mortality, During labor, the doula support is associated with lower rates of C-section birth, as well as decreases in other interventions such as medical pain management and instrumental deliveries, for example, the use of a forceps. Additionally, women who have doula support are more likely to initiate breastfeeding, are less likely to experience postpartum depression, may feel more confident about their pregnancy and labor, and have greater satisfaction with the birth experiences. And then, there are also lower rates of postpartum depression and lower rates of instrumental deliveries. Another example of an instrumental delivery would be the use of a vacuum during labor. So, access to doulas. Doulas are not covered by insurance, so they historically have been limited to people who can pay out of pocket. An NYC private doula can cost anywhere from several hundreds to several thousands of dollars. Only 6% of women have had a doula attend their birth. The main barrier to this is the access is financial. That's why we're excited to share what I'm here for today, the Citywide Doula Initiative. So what you're looking at here is the Citywide Doula Initiative and our mission, right? And there's some more details in the next slide I will explain. But what you're seeing here on the map on the right is what we identify as the tree map. So in April 2020, the city launched a task force on racial inclusion and equity, TREE for short, in response to the disproportionate impact of COVID-19 on communities of color. In partnership with the NYC Department of Health and Mental Hygiene, and utilizing pandemic health as well as socioeconomic indicators, the task force has identified 33 priority neighborhoods of focus, which you see highlighted here. There are 3 overarching components to the Citywide Doula Initiative. The first, and the one we will talk about the most, is providing no-cost doula care to underserved neighborhoods citywide, and 11230 being one of those neighborhoods, right? The second is expanding and strengthening the doula workforce, which consists of training community members to become doulas, providing apprenticeships and continuing education, as well as creation of a community advisory board to hear from doulas and community members alike about what is working and what isn't. The third is supporting hospitals in becoming more doula friendly, right? Because doulas are not the solution to everything, but we can help. So we can't do that without enlisting in the help of the hospitals. So this involves educating hospital teams about what doulas do, presenting at grand rounds, and strengthening referral pathways with hospitals. So the CDI mission, in short, is what you see here on your screen. We are hopeful that the 3 components of the CDI, expanding access to doulas, strengthening and expanding the doula workforce, making hospitals doula friendly, will achieve these outcomes. All right, so what you see on your screen here on the lower left are the infant outcomes. So typically when someone has doula support, these things will decrease, right? Preterm birth, low birth weight, breastfeeding will increase, mother and baby bonding will increase, infant mortality will also decrease. And then the maternal outcomes, the cesarean births will decrease, satisfaction in birth experience overall will increase, perinatal depression will decrease, severe maternal mortality and morbidity will also decrease. So these are the community-based organizations which make up CDI, right? So we're not just doing the work by ourselves. So earlier this year, when the mayor announced the Citywide Doula Initiative, it's in partnership with 7 other vendors, right? So now moms can get doula services across the 5 boroughs, and these are some of the places: Ancient Song Doula Services, the Community Health Center of Richmond, which is in Staten Island, the Mothership, which is, I believe, in Upper Manhattan, Caribbean Women's Health Association, which is on Church Avenue, East Flatbush, the Mama Glow Foundation, Northern Manhattan Perinatal Partnership, of course, by my side, and then Hope and Healing Family Center, which is also in Brooklyn. And so BPN isn't part of it at the moment, but I think that they will be joining us at the next round. But BPN does also provide doula services. So client eligibility. These are the basic eligibility criteria. There are no criteria per se, Undocumented individuals are also eligible. Uninsured individuals are eligible as well. The priority is given to clients who are in foster care, are giving birth for the first time. Let's say clients that are giving birth for the first time in general, let's say it's been 10 years, right? Because we know with science, things are always changing. So another eligibility is, a client that's perhaps had a previous traumatic birth experience, had no other labor support, having a high-risk medical condition. So I'm wrapping it up here. So how do you refer clients? So if you go to our website, for short, nyc.gov/health/doula, you'll find this landing page here, and you can learn more about what I've been speaking about. But to refer clients at this point, you would just go to the landing page, what I mentioned, and then you'll just look up to see if the client's zip code is eligible. But again, 11230 is one of the zip codes, right? So I'll save you some time there. And just to speak about Healthy Start Brooklyn pretty quickly, again, because By My Side originated from Healthy Start Brooklyn, and CDI is, I guess, I would say the baby of By My Side birth support, right? So this is some of the programs that we offer at Healthy Start Brooklyn. We have childbirth education classes, doula support, of course. We have a fatherhood program. We have mental health support. We have parenting education, which are, for example, we have a class called Family Foundations. So let's say a family is the parents are together and they want to learn better communication skills, or let's say they're not together and they want to learn better communication skills, that would be Family Foundations. And then our partners at Caribbean Women's Health, they also offer a parenting class. And one more parenting class is coming down the pipeline over at the other Department of Health building in Brownsville. So look out for that. It should be starting pretty shortly. And if you're interested in referring a client to classes, this is the landing page for that as well. And usually, there you go, nyc.gov/health/HSB is where you can refer clients to the childbirth education classes. We even have a class called Reach Out, Stay Strong Essentials, which is a class for new moms or pregnant moms to learn how to mitigate postpartum depression, right? So we have tons of classes, in short. So if you're ever looking for us and you want to know how to refer clients for doula services, these are some of the folks that I work with. Ashley, you can take a screenshot of this if you'd like, and you can email me. I'm the second person there. We have Cara Saunders, so if you're looking for somebody to come present in an area, Cara can come to present. And then you also have Gabriella, Mary Powell, and Regina. So, and that's it. Hopefully I didn't take up too much of your time. I'm gonna stop the share and let's see if folks have any questions for me. Or if they want to put the questions in the chat for the sake of time, that'd be great.
Oh, come on.
Any questions, Nina? Do you have any?
Yes. Sorry, I don't know why my video is being so funky, but okay, here we go. All right, doesn't matter. Anyway, so I have kind of a general concern, which maybe you can address. I've been familiar with your program for quite a few years, and I know that there's this whole initiative of updating labor and delivery units in a number of the city hospitals and so forth, and all of that is really great. But as someone who's been a midwife for a good 30 years now, my feeling is that none of this addresses a really, really key component to having best outcomes both for mothers and babies, and that's getting women in to early and regular prenatal care. And I'm just wondering if your organizations are doing anything to address this.
So I would beg to differ. I think that with doula support, we're birth partners. We're encouraging our clients to go to prenatal visits. We're asking them to check in on us, check in with us after prenatal visits. I didn't catch the other part of your question, but I feel like I think I heard something about midwifery and stuff. So everything that we have been doing at By My Side, we have is evidence-based. So we have articles that we can share with you, peer-reviewed articles that can help to perhaps, I guess, maybe lessen any concern you have, and then we could also have a conversation offline. But you know, our practice is evidence-based, and everything that we do is client-centered. So did I answer your question?
Yes and no. I mean, I'm not questioning the benefit of what you do by any means. So I'm sorry if it sounded like I was. And I'm very much aware of the evidence about doulas. But my question is, you know, is really with how are your organization, your affiliate organizations? I mean, what it sounded like women start working with the doula um, in the later part of the pregnancy. Is that correct? Did I
Not
misunderstand?
quite, because sometimes we do have last minute clients, but sometimes we have clients that are due in March, for example, right? So we encourage clients to reach out, the earlier the better, because it can really help build that rapport. And then in addition to, I think one of the other points where you were saying about just like, you know, increasing prenatal visits. One thing that we also are doing is part of the citywide doula initiative is getting into these hospitals to speak at grand rounds, right? Where there are residents, where there are nurses, and really kind of just letting them know the impact of doula care. And then we also have the Maternal Health Quality Improvement Network within the DOH, right? To help connect clients, or let's say a client has a bad experience and they're saying, you know what, I don't want to go to the hospital until I'm ready to give birth. What we can do is, you know, meet with those providers and kind of help mitigate whatever issue they're having to really center the client back to there and let them know like, oh, okay, look, you know, I had a concern, the concern was addressed. So I'm going to continue with my prenatal care. I'm not just going to walk in last minute, for example.
Okay, it may be that the question that I have is not really within your purview, and maybe that's the error on my part. But I guess, you know, so maybe somebody else who's speaking will be able to talk about, you know, answers that are more pertinent to that concern.
Got it. Got it.
Thank you.
Hi, it's Trinisha. Hi, Nina. I hear what you're saying. I think what you're saying is that doula care has a different aspect since it's not clinically based, and maybe it won't improve the maternal morbidity rates here in New York City, and that some of the proven ways to increase or rather decrease the maternal mortality morbidity may be centered around offering alternative forms of healthcare or even having providers similar to themselves, which is different than what a doula can offer. So I hear what you're saying, but it's like comparing oranges to apples.
No, it has to do with the fact that that women need to understand the importance of going, whether they're going to midwives, whether they're going to an MD clinic, that's not, you know, I mean, that's their decision, I think, although of course I'm biased toward they're going to midwives whenever possible. But the idea is that, you know, they really should be starting prenatal care by, you know, 6 weeks if possible, even pre-pregnancy, 8 weeks if possible, rather than, you know, finding themselves you know, getting into a clinic by say 28, 29 weeks and then hearing about your program. So there's a lot that goes on before they get to that point, and I think that that's really my concern. I absolutely think that what you offer women is fantastic, and I don't want to be misunderstood on that, you know, as far as that goes. My concern is with the other stuff that doesn't happen for many women, and how do we, you know, how do we bring them into the picture and emphasize the importance, communicate the importance of getting care. So thank you.
No problem. And I think one last thing I'll say about that point is, you know, I think sometimes what happens when people are seeking prenatal care is that depending on their insurance, they're kind of being shuffled around, you know, to different providers and stuff. And sometimes it discourages them. And then another thing is too, is that when they go sometimes to visit providers, they're spending hours in the waiting room, right? Which is like, oh my God, I'm pregnant. There's only a vending machine here. Like, you know, if I don't have to come next week or 2 weeks, you know, I won't come. So, and then also the antiquated ways of like, let's say you call a hospital and you need to speak to your doctor, right? Like, can you imagine how many channels? I mean, we've all been through it. So I think it's just more so just getting rid of the old ways of doing things and, you know, being more innovative and really getting people to say like, oh no, you're going to come to an appointment and, you know, your doctor's not going to be triple booked and you'll be able to get in within an hour of seeing them. I think that would really encourage folks. Of course, we could go on all day, but I know we are only here till 8:30. So
That I love that, Berenice. It's the whole culture of healthcare and how it interfaces with women in general from early ages on. And I see that Joel, I'm jumping in to help, but if you want me to back out, I will. But I do see that Carl has a hand up.
I didn't see. Okay. Oh, you're on mute.
Hey, good evening, folks. So, Berenice, thank you so much for the presentation. I have a few questions. They'll be real quick. So I believe at some point in the presentation, you had mentioned where the funding comes from. Remind me again, is that a federal grant, right?
So with By My Side is a federal grant, but as of March, we also have the Citywide Doula Initiative, and that is a city grant from the mayor.
Okay, got it, great. And so basically, my question for that is the funding guaranteed basically for, the entire duration of the administration, or is it something that gets basically renegotiated every year with the city budget?
No, from what my understanding is it's pretty concrete. Well, from what I understand, it's about a 9-year funding. So yeah, we'll be here.
Okay, awesome. So that's it. I just wanted to know like the funding and the longevity of the funding for it. Okay, thank you so much. I appreciate that.
No problem.
Thank you, Bernice. That was a very interesting presentation. Any more questions? Because our next guest, I guess, Professor Romero is not here yet.
Yeah, right. I got a bounce back on my reminder just now, so I think we might not be hearing from the HEAC program this evening. We'll try to bring them back. So Joel, Joel and Nina, if you wanna switch, go right ahead to Rebecca Herman, and then the good news is that this leaves extra time for Dr. Kodorf, who is here to join us and has some information to offer as well.
Okay, sounds good. So, and I saw Rebecca shaking her head. Stuff that was being said, so she probably has some things to add to what we've heard already. So Rebecca Herman is with the Flatbush Behavioral Health Center. She's the Assistant Director of Field Operations and Clinical Director at the Flatbush Recovery and Wellness Center. So tell us more about what you do, Rebecca, and you have the floor.
Sure. Thank you, Joel. My name is Rebecca Herman. I am a licensed clinical social worker, and I'm also a master level CASAC, that's a credentialed alcohol and substance abuse counselor. I have been at the Flatbush Behavioral Health Center for about 2 years, and I have many titles, which basically means that I have a very busy.
You just went quiet, Rebecca.
Oh no! Hear me now?
Very
Not
quiet.
Far away.
I don't know why. I don't know why it sounds so low. I'll try to speak louder.
No.
Hear it. No good?
Yeah, like 30 seconds ago, you were really clear, and then it suddenly just cut out, and then you sound really far away now. So.
Oh, I just zoomed in. That wasn't the volume. Let me try something else. How about now?
No.
Rebecca, is your audio through the whatever computer you're using, or like your device, so like headphones or something?
The computer.
Okay.
I can hear. I don't know how it comes out on the recording, though, whether that's going to be an issue.
Try one more thing. Can you hear me now?
Very faint.
Still very faint. Okay.
Yeah, just if you could try to get real close to your speaker, your microphone, see
microphone.
if that helps.
Sure. I think I know where the speaker is. Okay, I do apologize. I mean, that makes things a little awkward, but if you can hear me at all, I am.
Yes.
Okay.
It's getting better.
Okay. I am basically what I
There you
want to
go.
talk about today is the services. I'm really loud now. Is that why y'all are giving me? Okay.
You're just right.
Okay. I wanted to talk about the services that we offer here at the Flatbush Behavioral Health Center, which is part of something called a Certified Community Behavioral Health Clinic. We are part of Catholic Charities Brooklyn and Queens, which is the largest Catholic charities in the United States. We have over 160 programs over Brooklyn and Queens, but the Flatbush Behavioral Health Center is the only Brooklyn-based program that offers mental health and substance use services under one roof. So Carl was speaking about funding a minute ago. Our funding comes from SAMHSA, from the federal government. We were the recipients of a very generous grant to fund our certified behavioral health clinic. So we are able to provide a multitude of services right here in Flatbush. We are located in the Flatbush Junction area. So right where the Aldi's and the Target is and everything, the TD Bank parking lot, we're towards the back. Our offices are in the very back of that parking lot. I'll tell you a little bit about the services that we offer here at the clinic. Here at my clinic, we offer mental health services. We have a team of psychiatric nurse practitioners and licensed mental health, or excuse me, we do have some mental health counselors. We also have licensed social workers here, and they provide individual psychotherapy. And of course, the psychiatric nurse practitioners, under the guidance of an MD, the psychiatrist, provide psychotropic medication management. The program, when I came on here, the program that I was hired to oversee was what was then called the Flatbush Addiction Treatment Center. We've changed our name to the Flatbush Recovery and Wellness Center to better reflect our client-centered approach and general recovery approach, as opposed to healing from a disease, and kind of to take the addiction piece out of it, because that word carries so much stigma, we find. But anyway, that's kind of my bread and butter. That's the thing I get most excited about, is promoting that program, because within the CCBHC, you know, we have mental health, we have some nurse wellness services, but we also have the addiction services, which I find are kind of unique in this area. I don't know of a bunch of addiction treatment centers in the Flatbush area, but there is a demand. And the kind of treatment that we provide here, we offer an array of services. We, of course, help people who come voluntarily. We help people who are mandated by the courts. We also have a DWI track of program. We work closely with Brooklyn Task to keep folks out of jail and put them in a program instead, make them do the course of the program in order to get their driving rights back. And as of recently, we've really been promoting the use of medication-assisted treatment for opioid use disorder. We've always provided it for alcohol use disorder, and that's been pretty well received among the population here. It's been a little more challenging to get the opioid treatment off the ground. We know there's an epidemic out there. We know there's a stigma attached to it as well. There's an initiative, though. Actually, we were part of an initiative from the Department of Health and Mental Hygiene to reduce barriers to accessing opioid medication-assisted treatment. And when I say that, what I mean is primarily the trade name Suboxone. So the sublingual tablets, it doesn't carry as much of a risk of overdose or abuse as methadone, and it doesn't have to be prescribed in the everyday clinic setting like a methadone clinic, but it also carries its own unique set of challenges, primarily the induction piece. So, but we're really excited about that, and we're also offering the MAT in the Article 31 licensed Office of Mental Health Clinic, which is the Flatbush Behavioral Health Center. Those are the two big things we have here: substance use and mental health. We also have an internal mobile crisis team, which provides 24-hour emergency crisis intervention and stabilization to Catholic Charities clients and to clients who may call the call center in distress. So we do get some clients who aren't within our agency just yet, but they're in need. So they call our call center and we do assist them. We have benefits coordinators on site that help connect clients with nutritional assistance, SNAP benefits, housing vouchers, insurance, re-upping their Medicaid, things like that. We have an LPN on site who does health screenings and overall wellness and runs a wellness group. We have targeted case management, which is both, we have a Medicaid, targeted case management for Medicaid clients and for non-Medicaid. Depending on your insurance, you go to one of the two programs, and that's like the health home model, where you're getting a lot of intensive assistance, making your appointments, getting applications for housing completed, things of that nature. And the other thing that we do here is we utilize peers, certified recovery peers. We also have a veterans peer here to cater to the veterans environment, or the veterans that we had coming on. Yeah, so we utilize the peers as kind of a half step between the clinical person and, you know, I like to say that a peer is someone in between being a clinician and being a support. You know, it's kind of like they're partially clinical, but mostly they have lived experience. So they are able to meet the clients sometimes in a way and connect with them in a way that we as social workers or, you know, licensed health professionals cannot. So that's basically the whole spiel. We like to think that if anybody walks in our doors here at 1623 Flatbush, that they would be provided services and given all the wraparound services they need. The only thing we don't have on site at the moment is primary care, but we do work with New York Presbyterian in the Flatlands area, some of their clinics. We refer to their clinics quite a bit. And we do have a pharmacy on site for our clients and for our staff. It's a Genoa Pharmacy, not affiliated with Catholic Charities, but it is we contract with them to provide pharmacy services on site. So that is kind of my program, my agency, my place here in a nutshell. Any questions? Referral process, anything like that?
What did you say the name of your program was again?
It gets confusing, I know. So it's called the Flatbush Behavioral Health Center, and that's the name of our certified community behavioral health clinic. It goes by that name. It's also the name of our mental health clinic, so that's where it gets a little confusing because it's the name of the big place and the one program. But that is the largest program that we have within the CCBHC, so I think that's why they chose to share the name.
What's the best way to make a referral to your organization?
The best way to make a referral is to go through the Catholic Charities call center. It's a well-staffed call center. They're open Monday through, I think they're open Monday through Friday, even though we close early on Fridays. They are open Monday through Friday, 8:30 a.m. to 6:30 p.m. And I'll give you that phone number, and then I'll pop it in the chat as well. The number is 718-722-6001. And that is how you would make a referral to our clinic. You would connect with one of the staff in the call center who would take insurance and demographic information and pass that information on to us. Quick word, Catholic Charities, like I said, we have 160 some odd programs over Brooklyn and Queens. So if you had somebody who was interested in something like immigration assistance or food pantries, things like that, that we don't deal with right here at my center, you can call that call center and they'll make a referral to those programs as well.
So Rebecca, this is Joel. So basically your clientele comes from the Catholic Charities network.
No, just for the mobile crisis team. When I was speaking about referrals to our mobile crisis team, we are not part of the, let's say, the city hospitals. Like Woodhull has a mobile crisis team. We're not like them where we take anyone, you know, and just get called on 24 hours a day. We're mobile crisis for our folks primarily, unless of course we get a crisis call coming into the call center, someone feeling suicidal or at the end of the rope, so to speak. You know, we would connect them to a mobile crisis clinician and follow up with them as well, without necessarily making them a client of ours.
But the services that you provide, the addiction services and mental health, your clients come from where?
We get clients coming from, we have what we call UCPLs, which are urgent care clients who will come as direct referrals from hospitals, people being discharged from psychiatric emergency rooms, psychiatric stays, inpatient detoxes, and inpatient rehabs. Those referrals come directly from the hospitals, from the social workers there, but anyone can, excuse me, anyone can call the call center and they can ask to be connected with us. I'm also gonna, once I find the chat, there it is, there's the chat. I'm gonna put in the call center's number, and then I'm gonna put in my email address as well, because I find that sometimes, you know, we're such a big organization and the official line is to have people go through the call center to make the referrals. But if you have questions, or if you want to refer someone, or you think someone might be a good referral, you can go ahead and you can email me and we'll have a chat. It's not a problem.
Rebecca, that's so typical of the way you operate, and I want to thank you for it. You're always like so accessible and responsive, and you've been great with some of the concerns that sort of swirl about your program site. You get scapegoated sometimes, and you've always reacted to that in a way that is just really graceful. So thank you for that. And while you're putting that in there, I'm going to note that Carl has a hand up, which I think means he has a question. I'm astute like that.
You are Captain Obvious, Sean. So yes, you are astute. That's true. So Rebecca, Sean, you did like that one, yeah. So Rebecca, thank you very much for the presentation. Let me think. Which are the? Yes, these are the questions I want to ask. And so the first one is from where you sit. Did you see, you know, a moderate, a sizable increase, or no increase in, you know, basically the number of cases you were getting, you know, basically from the pandemic to now? And then the follow-up question to that is, like you said, your organization liaises with many other different organizations for wraparound care. And so my question is, my follow-up question to that is, we're about 2 3/4 years into the pandemic. So if the speed had slowed down with which these other organizations got back to you about the people who are affected, are you seeing that speed increase or stay the same? Because a lot of organizations have also been hit hard in terms of they're losing people as well, you know, during the pandemic. So those are my 2 questions for you.
Okay. The first part of your first question, you were asking about kind of if I'm kind of paraphrasing, if we saw more traffic since the pandemic with regards to behavioral health concerns, mental health. Yeah. Mm-hmm. So the answer is yes. We have seen, especially in the mental health clinic, we have had such a demand. And kind of on the same note, we were a little short-staffed earlier in the year. We saw a lot of people resign and take positions a lot of remote positions. And by the way, most of our clinicians are all on site. We have some people who do a hybrid model, but for the most part, we're all on site. And we lost some people because they wanted to go someplace where they felt safer and they could do the Zoom thing. So it had been challenging because the need was still there in the community. We were still taking in urgent care referrals and managing to connect them with therapists and psychiatrists, but we did have to slow down our rate of accepting open access walk-ins, which was hard to do. It's hard to tell people who walk in and need services that there's nobody here to see you today, here's a referral somewhere else. The good news is that we are much better staffed now and we're receiving those referrals and we're able to address them. The bad news is there still are a lot of people. There's a big demand, especially in the community here. People just coming in as walk-ins and needing assistance. There's so many gaps in the mental health system. Something in between, you know, it's just that. I could go on forever about it, but it is hard. It is challenging. I would say that I do see it getting a little better. What is surprising to me is I know that the opioid epidemic is not getting better. We know that from what we see in the news and what we see in, you know, all the research and everything that talks about how people are, you know, especially coming out of the pandemic, that they were overdosing and they were, you know, they weren't getting their medication. So they were turning to harder drugs, all that. What's been a little frustrating on my end is that I know the demand is there, but it's been hard to engage with those folks sometimes. I think it has to do with the stigma. So to kind of in a roundabout way answer your question, I think that There's absolutely, the need is increasing also for substance use services, and we're here and we're ready to meet that need. We're waiting for the folks to come in the door, pretty much.
Got you. Thank you for that, Rebecca. I really appreciate it.
No problem. Thank you.
Florencia Chang Ajeda had a hand up, and then Nina's hand is up.
Florencia?
Thanks, Sean. Good night. Hi, Rebecca. How
How
are
are ya?
you? I'm great. I'm great. I want to thank you for always assisting with our community projects, always sending out help in the time of need. Thanks for the work you're doing within our community. There's a question I have to ask. A lady the other day asked me, although I didn't know where to turn for her, but she has a son who has mental issues. He's supposed to, I think, go to the hospital to get his shot. I don't know if it's once a month or
Okay.
however, he does not like going to the hospital. So she was asking, if there's anywhere that he could go to that would administer, or like figure out what he needs or administer what he needs. So are you aware of, is this something that your organization do, or is there another organization that they can be referred to?
We absolutely do. And it sounds like, if I were to make just a real quick generalization on what you said, it sounds like maybe it's a Haldol shot that he gets, or maybe it's a Abilify on a monthly basis.
Not
And
sure.
we absolutely.
She didn't specify.
Yeah. Either way, the fact that he's on a monthly injectable shows that, to me, that's kind of like a clue in that he's somebody who really is in need, and we would absolutely take him. If he's looking to leave his current placement, we do have open access hours. Our open access hours are Mondays and Thursdays, starting at 11 a.m. And that's, like I was saying, that's when we take in people. We open our doors to folks who want to do a walk-in appointment, and we do our best to accommodate them during those times. So I would recommend, I would recommend you could go through the call center. I gave you guys that number, or you could just have them do a walk-in on a Monday or a Thursday. And we would coordinate with where he was coming from to make sure that we were, doing good continuity of care and not just starting with a whole new regimen. But
Right.
yeah, absolutely. He can get that in a clinic setting like this. He doesn't have to go to a hospital.
Okay, great. I'll pass on the information. Thank you.
Thank you.
You're welcome. Nina, you were next.
Sure. Thank you. First of all, this is just really great to know about, because so often I have women who come in for women's health services who clearly are in need of other resources, including mental health resources. So I really appreciate getting an update here. I have a question regarding the opioid addiction issue. I know in New York State we have a STOP program where if you, as a clinician, say, are prescribing an opioid for any reason, you have to check and find out if the patient is getting them from some other place. It's supposed to be registered. I know that, hopefully all responsible clinicians are much more aware and much more I guess, conservative and thoughtful about when and to whom they prescribe opioids, because they do have legitimate use, certainly. So I'm just, I guess I'm just, I don't know, baffled, maybe, for lack of a better word, that we can't, where are people getting these drugs? Are they getting them through legitimate sources, or are they resorting to, on the street resources? Do you have any insights into that?
Unfortunately, I do. It's something I've worked in addiction for many years, and I used to work in the methadone program, and I'm familiar with what you're talking about, the iStop registry, where you put the medications in. There are some less than legitimate doctors out there, not the majority. There's a handful, and most of them get gets stopped pretty fast. But it does happen that there are what we would call pill mills, or what we used to call at the methadone program, croakers, doctors you knew you could go to and get whatever you wanted, pretty much. A lot of times for folks, though, I would say that's not the problem. The problem for a lot of people is the these medications for pain, chronic pain, and things like that. People were started on them and they weren't aware. And to be fair, maybe some of the prescribers weren't fully aware, as they should have been, about the addictive potential. And what I've seen a lot of in my career, anyway, is people who have they've built a tolerance to it, and then they need to get more, and the pills are too expensive, so they turn to heroin. They turn a lot of times to intranasal heroin first. They don't usually just go right to IV usage, but for most, especially most of the young folks that I've worked with in my career, that's kind of been the trajectory, unfortunately.
Mm. Thank you.
Any more
There's
questions?
a question
Yes,
from Berenice, and I think
Berenice.
you want to turn it over.
Yes, I have a quick question. Does your site also provide services for children?
We do. I'm glad you brought that up. We provide, strictly speaking, if you look at our website, the websites for our mental health clinics, we provide services for children ages 5 and up. And for the addiction, as I call it, the addiction program, the recovery program, we provide services for children 13 and up. So it's adolescents for the recovery program. And we are looking, I've been trained in something called child-parent psychotherapy, which is a specific track of treatment with young parents, not just mothers, but parents and children 4 years of age and lower, up to as low as 6 months. So that is something that we will be doing in the mental health clinic in the future. We'll be ramping that up and advertising that a bit more. So I say this to say that right now it's pretty much kids 5 and up for the mental health program, but in the very near future, we're going to be doing the parent-child practice here with children who are under 4.
Thank you. And then one other question, I guess another part. What about like IEPs, or if, you know, someone has a child and then they're told they have to get an IEP, or they want to get like a second opinion, do y'all offer that as well?
That's a little tricky, and that's an agency. That's more of an agency call than a call at my level. We're a huge agency. We're Catholic Charities. We're kind of I hate to put it that way, but we're kind of a target for lawsuits and things like that, you know. So it's kind of, they're very conservative at this agency about giving clinical opinions on things in writing. So I would say if they wanted a second opinion, I'm just being completely frank with you. If it's a situation where somebody needs a second opinion on something and they need it written, I would say this is probably not the best place for that. We could, of course, do a basic write-up that said when they came, how long they've been with us, their medications and their diagnosis, but that's pretty much 95% of the time the extent that we would do.
Anyone else? Question? Rebecca, that was great. I see the people here know you better than I do, and it sounds like you do great work.
Thank you. Thank you for having us.
Yeah, you're welcome. Thank you. So now, Sean, did you want to let Dr. Kodo make some sort of presentation?
Yeah, please. We weren't able to add you onto the agenda, and we could bring you back for a longer, but I know that appreciate you being here, and know that you had some information you wanted to briefly share.
Sure, I'm delighted to be here, and thank you for the invitation. I'm here really to talk about our diabetes center that we created in the last 6 months. With Nina, Nina and I don't just work in the same building; we work in the same corridor of the same building. So we're located at Utica and Eastern Parkway, and just a little background that a map of where there aren't enough doulas that we saw in the first presentation. That exact map could have been the map of where there was excess COVID deaths. And it also could have been the map of where too many people have diabetes and complications from diabetes. So that map shows up all the time. And as just a little background, as we in 2020, when we were just besieged in central Brooklyn with COVID-19 mortalities, and those maps started coming out, and we observed that there was a huge disproportion of people who were dying from COVID who had diabetes. At one point, about 43% of our patients at Kingsbrook, for instance, who were admitted with COVID had diabetes. We realized when we got through this first wave that we had to create something that would really address the epidemic that was underneath the pandemic. So we really built this on three sort of planks, if you will. One is we had to create a team. Two, we had to get the right technology to the patients. And three, we had to expand self-management. And we actually expanded self-management through kind of a unique approach. So building a team, right now, we used to have just like a couple of like endocrine clinics, and that was way insufficient. We knew we had to be there 5 days a week in person and really 7 days a week, either virtually or through the patient portal. When you're managing a chronic disease, episodic care never works, and people never know when they're going to need to reach you. It's never going to work out to be episodic. So we expanded our hours greatly. We're there now. They're really continuously during the week, and we have weekend telemedicine accessibility. We converted our RN to a certified diabetes educator who's dedicated to that. We hired a nurse practitioner who does nothing but endocrine and metabolic care. We brought in a PharmD to do medication management. We have a health coach who's dedicated to this. We have a new nutritionist who comes in twice a week to do one-on-one nutritional counseling. We have a behavioral health specialist who works with patients who have distress. So we built this team. We also added the technology that we think really makes this work also. The most important technology is continuous glucose monitors, which has really revolutionized the care of people living with diabetes. These are those little devices you've seen people wear on their arm or their belly. It continuously measures blood glucose. People share their data with their healthcare team. Most people elect to share. Some people don't, but I'd say 99 out of 100, if you ask, can you share your data with us? They say absolutely. This gives us both access to what's happening between visits and on a daily basis. We really look at these readings and see who's in control, who's not in control. A lot of times the insurance doesn't pay for this. So we were fortunate to have some charitable support, external funding to purchase some of these devices for patients that insurance wouldn't pay for. Commercial insurance pays for it, $11.99 pays for it. It's a struggle to get everyone else to pay for it, although New York State has sort of improved the regulations on this. We also invested in a retina camera. This is a camera that can take a picture of patients' retina right when they first come and see us, so we can shoot it to an ophthalmologist, find out very quickly whether someone has diabetic retinopathy without actually seeing the ophthalmologist. If they have disease, then they have a formal visit. We have point of care hemoglobin A1C testing, which is a new device which we added. And of course, we really optimize use of our EMR, especially the patient portal, so people can shoot us their blood test results and glucose readings between visits. So the technology was expanded, the team was built, and then the self-management education was also critical. To do that, we strongly believe that the best self-management would come from highly trained peers. So we coordinated with an organization called Health People. Chris Norbert is their CEO. They do a lot of work with HIV and also diabetes self-management. A little more in the Bronx than in Brooklyn, but we're very eager and excited to roll up their sleeves and come to Brooklyn. We've trained so far 15 peer leaders to teach diabetes self-management. Our patients absolutely love these classes. because instead of like a registered dietitian or a nurse practitioner or a PharmD telling people what to do, they have a very highly trained person who actually has diabetes and can say, you know, here's how this is what I do when I'm in that situation. And it becomes also, there's a socialization event there. We just started those classes. We're maybe at week 2 or 3. These peer leaders were trained just about a month ago. This program really launched in the late spring. So we're really excited about this. We think the expansion of the hours, the team we have, the use of technology. We also use a fair amount of insulin pump technology, which we don't see a lot in Central Brooklyn, but when patients are appropriate, we definitely use insulin pumps. And then the peer-led classes, we think we've created something that is sustainable and accessible to more and more patients in Central Brooklyn. And that's a quick flyover of our diabetes center. I'd be happy to answer any questions.
And in the interest of time too, we'd be happy to field any that come. If people want to send us an email and we can send it over, we can also send it to Tahisha, who's been just great. And I really appreciate you wanting to acknowledge that you're here, and thank you for everything, all of your communication and support. And seeing no hands from anybody who wanted to quickly try to get a question in.
Oh, I saw a chat question.
Yeah, Berenice put a question in the chat. Yeah.
Yeah, and Tahisha can help us out and provide all the contact numbers and address. But we're at 1110 Eastern Parkway, which is the corner of Utica and Eastern Parkway. It's on the second floor. It's right at I guess it's the 3 and 4 subway and the 46 bus. One other, I think it's the 11 bus there. So it's a little bit of a transit hub. We have a office manager that manages all the referrals there via the fax machine is like literally a foot from her arm. And that's how we get most of our patients. But we have patients from all over Brooklyn coming there now. And we're, if there's an urgent circumstance, we see patients right away. Sometimes the same day, sometimes next day. We get referrals, for instance, from our wound care center of people that are facing amputation, and so we don't wait on those patients. We try to see them that afternoon or the following day to try to save their limb.
Yes, I just wanted to add also, hi everyone. I think I was on mute when I said hi everyone. Thank you so much for having us, Dr. Kadra. It's always an honor to hear you speak this wonderful care that you do with the patients, especially with the diabetes community. And thank you so much for having us tonight. I wanted to add that with the DSMP program, which is the diabetic self-management program that we have running right now, this is fairly new, like Dr. Kadra said. So we will be commencing new cohorts during the day and also next month as well. So if your organization would like to start a class session, we are open. We're opening opportunities for the community for nighttime classes, afternoon classes, because we really want to make sure that we bridge that gap between our community and give access to our patients who are struggling with diabetes and to make a difference within our community with One Brooklyn Health. And Pierre Toussaint is available. We have so many other services that we offer as well. But tonight we wanted to focus on diabetes because November is Diabetes Awareness Month. So we are open to any other questions that you guys may have. I will definitely leave my contact in the chat. Should a question come up, please feel free to email me. Once again, thank you so much for having us.
Thank you.
I actually had some questions.
All right, Nina. Sure.
Yes, I'm big on the questions tonight, but healthcare is my thing too. So two questions actually. One, is how would somebody who's not a Kingsbrook or One Brooklyn Health patient get referred? And number two, has there been any thought to addressing the just staggering number of young people who are being addressed, so that, the maybe, support group, peer group, other kinds of educational things that really focus on, say, teens and young adults, because we know that the kinds of social situations, other kinds of pressures and things that they deal with are different than, say, someone who's 40.
Yeah, uh, great questions. Even only about 40% of our patients come internally from One Brooklyn Health. Most of the patients, the majority, actually come from outside the system already. They come from community-based physicians. They come through self-referral. So the way they get into the system is really just through the fax machine, through a fax, because they're not already in the EMR, so they have to have sort of an indirect referral instead of an internally. But as I said, about 60% of patients come already from outside the system. And that's Tahisha can provide that mechanism. It's pretty easy, and as I said, we're really mindful of people not waiting for appointments. We do the best we can. The young patients with diabetes, a couple of things. One is we do have a diabetes prevention program, which is run by a health coach. You may know Janine, and that's another conduit to getting care for people who have pre-diabetes. And you're correct that the young patients are a little bit of an extra challenge because it's a different disease. It's a different disease if you are 22 years old and you have diabetes, or especially if you have type 2 diabetes, compared to the same exact disease in someone who's 65 or 70 years old and develops type 2 diabetes. I'm always teaching the medical residents, because they see patients who are 19, 20, 23 years old, and they have hemoglobin A1Cs that are 6.2 or 6.3, and they sort of think to themselves, well, this isn't so bad. And I turn to them and say, this is a 19-year-old. This is not a 75-year-old with an A1C of that level. This person has to get into a lifestyle program to avoid really catastrophe. So you're correct. Everything we can do to bring into the fold those young patients, the outcome is amplified 1,000-fold. I think the diabetes prevention program helps. I think really educating patients on the significance of prediabetes in that age group. That's not an inconsequential discovery, prediabetes in a 20-year-old. That is a serious identification that has to be addressed. And the good news is that there's a lot of ways to manage it now. Diet and exercise by far are the best, but there's medicines that look pretty safe with few side effects and can really forestall the development of diabetes. So when diet and lifestyle fails in that group, we're not hesitant to add some type of medication that may prevent diabetes.
Thank you.
Dr. Kadrov, I think there's another question about gestational diabetes that Berenice.
Yeah.
So
It's also a great question. We don't do a lot of work with gestational diabetes because what happens is, at least in the local areas, a lot of those patients get sort of swallowed up by the high-risk pregnancy teams, and they tend to do the day-to-day and week-to-week management. We used to do a little bit more in the past, and what was happening is the insulin was being adjusted by two teams. It wasn't really the best care. I think the solution to that really, if we're going to do it, and we'd be happy to, is to have actually co-located obstetrician, high-risk pregnancy, and endocrine. If it's co-located, I think it can work extremely well. But otherwise, it gets a little disjointed. And so most of our patients, they end up being managed in various very well-run high-risk pregnancy programs during the, prenatal and perinatal area time.
Florencia Changa-Jada's had a hand up for a little while, and then I think Tranisha Williams wanted to just quickly give a shout out about her program.
Yeah, thank you. Thanks, Sean. And thank you, Nina, for asking that question. I was going to ask about the young people, but I also wanted to ask about, it was brought to my attention with this little girl that her sugar level was like 300, in the 300s. Her mom is a diabetic, but her mom is not taking the child to the doctor for that. So what can be done for a child like that?
For a child who's how old?
I'm sorry, she is 12 years old.
Well, I mean, she would need the best care would be through a pediatric endocrinologist who can bring those sugars down. It would depend on how she's managed. Would depend on what type of diabetes she has, which usually can be figured out on the first visit with a couple of basic lab tests to see if she's making insulin or not. But someone like that should be seen by a pediatric endocrinologist pretty quickly.
If there's any follow-up to that and you want to exchange information, you can go ahead and email the office, and I'd be happy to provide any numbers to call, Florencia. And I think that wraps up the questions on this impromptu but really thorough and interesting and appreciated presentation.
Well, thank you. I'm delighted to be here, as I said.
Yes, thank you. Tanisha, did you want to speak for a while?
I can speak for a few moments about one of the things that I'm working on. I am a midwife of 20 years living in the central Brooklyn area, and I'm currently working on a birth center with a couple of colleagues. It would be New York City's first nonprofit birth center called Haven Midwifery Birthing Center. And the reason why it is different than most other birth centers is that it is a nonprofit and it is midwifery led. We're currently in the stages of trying to locate a space, and we want to place this birth center somewhere in the Flatbush area because we notice that is where there is higher levels of maternal morbidity and mortality, particularly plaguing marginalized communities. And I just wanted to share that with the board, and if anybody had any suggestions of where we may be able to place this facility. If anybody knows anybody who's interested in supporting us, we want to hear about it. So that's all I wanted to say.
Yeah, let's circle back to one another, because I'd be happy to share information of the like our business improvement district directors would have a good insight on vacancies. And so if you share the specs that you would need, they might be a quick way to locate space.
Okay, that sounds wonderful.
That's what I'm thinking of off the top, but let's talk more about that. Co-chairs, I'm seeing no more hands, and there's nothing else on tonight's agenda.
No, Nina, do you have anything else? Florencia.
I just want to check that Florencia, is her hand still up, or does she have another question?
Oh, I'm sorry. I should have taken it down. No, thank you. I'm good.
No problem.
Thanks, Nina.
Oh, I see another hand just popped up. Berenice, go for it.
Thanks. It's Berenice, but yeah, I just want to also just vouch for Tranisha and say she's an awesome midwife. I've had clients that have been referred by Tranisha, and I've also referred clients to Tranisha. So I just want to say that I'm excited to see Haven Midwifery Birthing Center come to fruition, because we don't really have a lot of birthing centers. So whatever we can do to get this ball rolling, I encourage everyone to they just need a home. it's such a beautiful project. So
Yeah.
I just wanted to say that. Of course, I'm a doula. I'm biased, but it's
Well,
coming from a good place.
the health disparities, I can't remember the numbers, and maybe you know them off the top, but the health disparities when it comes to perinatal, prenatal, postnatal care in Black and Brown communities is stunning, like stunning. And so yeah, this is where that needs to be. And I was remiss and Joel Dessou from Councilmember Rita Joseph's office has also been on this meeting with us for the duration. We were joined a little bit earlier by Dan and Councilmember Farrah Lewis's office. So thanks to both of them, but also good places to go for additional support, the city council offices.
Nisha, how many square feet do you think you need? Like just,
We would like minimum of 5,000 square feet.
oh, big space.
Around 6 or 7 would be probably preferable. We need space for birth rooms as well as clinical offices, as well as a kitchen area. There's a whole rules that the state has sort of designed for birth centers, so it needs a little bit of space.
You have to comply. Okay, we'll keep our ears open. So, okay, that was a really interesting evening of presentations. You know, some great things going in our area. And thank you all you dedicated people in the health professions for your work for the community. It's very much appreciated. So, do I have a motion to adjourn? Somebody?
You can just do that by fiat in a committee meeting.
Fiat. Nina, you up for adjourning?
Sure, it was great. It was really good hearing from everybody and to hear that things are happening here in our neck of Brooklyn.
Thanks everybody for all the work.
All
And
right.
there is information in the chat. If anybody missed it, we'll be capturing that. So again, you know where to find us for any follow-up whatsoever. Thank you all very much.
And this is on YouTube if you want to review, you know, anything that was said. So thanks everybody and good night.
Thanks, co-chairs.
Don't
Good
for-
night.
Don't forget to
Thanks,
vote.
everyone. Good night.
Bye.
Thank you. Good night.
Bye-bye.